Hello, everybody. I'm Dr. Gerald Appel from Columbia University, College of Physicians and Surgeons, and we're going to go through some questions and answers on glomerular disease. We're going to cover especially areas that have not been covered in detail during the other lectures during this course. Now, just as a matter of background, I am a tenured professor at Columbia. I've been co-director of the Glomerular Kidney Center for a long time. I've written almost 400 manuscripts and book chapters, and they deal with glomerular disease, and that's what we're going to focus on. These are my conflicts of interest. All the research grants are through Columbia University. I don't get any money from that. The consultations are with many companies, usually on new medications, and unfortunately, I have no major stock holdings. So let's go right ahead with question one. Which initial patient presentation is least likely to be associated with new onset minimal change disease? We have a patient with new onset minimal change disease, which is least likely? A 65-year-old man with AKI and 4+ proteinuria, a 32-year-old female with 2.1 grams of proteinuria daily, a 45-year-old male with 9 grams of proteinuria daily, or a 28-year-old male with high blood pressure, microhematuria, and 4+ proteinuria. So looking at these, the one that is unusual for minimal change is the 32-year-old female with only 2.1 grams of proteinuria daily. Usually, the proteinuria is very heavy in minimal change disease. I like to tell the house staff minimal change disease is like pregnancy. You don't get a little bit of pregnancy, you don't get a little bit of proteinuria and minimal change. You get full-blown nephrotic syndrome. All the others have either 4+ proteinuria or 9 grams. They could all be minimal change. And this slide shows you the data taken from a study we did on 95 adults with minimal change at Columbia University Medical Center over a 15-year period. I would point out that the GFR was slightly low and the creatinine slightly high in these patients, again, maybe due to hypoalbuminemia. The average proteinuria was almost 10 grams a day. You do not get a little bit of proteinuria at the initial presentation here. AKI, quite common, especially in the older patients, 17% initially, so that would fit again. And we found no difference between daily and every other day steroids, but we'll come to that a little bit later. So question two, in general, adult patients with minimal change disease respond to steroids similar to children and can be considered steroid resistant if they do not have a reduction in proteinuria by 2 months of therapy. Is this true or false? Well, you've got a 50% chance on guessing on this one. So the answer is adults are not like kids. Kids are not small adults. Adults are not big kids when it comes to minimal change disease. This is a study it's a composite by Dr. Vivarelli, who looked at 2 studies in kids with minimal change. And you can see virtually everybody who was going to go into remission, almost all with steroids, did so before 8 weeks, before 2 months. A child who hasn't responded by 8 weeks is considered steroid resistant. If you look at the adults from our series of 95 patients and another large series in adults, look over time. It's really 4 months, 16 months when the curve flattens out, and then there are no more remissions than you got before that. So an adult is not considered steroid resistant until they've had 4 months of therapy. The kids are resistant if they fail to respond in 2 months. Now, what is the initial therapy? I'm going to try to refer to KDIGO guidelines, the guidelines which came out at the end of last year in Kidney International, as often as possible. I'll tell you when I agree with it and when I disagree with it, but at least you see what the guidelines are. So for minimal change in adults, if there's no contraindication to steroids, they recommend glucocorticoids. If there is a contraindication, you can have cyclophosphamide, calcineurin inhibitor, mycophenolate, or rituximab, and they have a question mark there. What are the contraindications? Obesity, diabetes, cosmetic concerns in many younger people, that prior problems with steroids here. Now, I would not leave the rituximab here with a question mark, but nevertheless, most people would start with steroids. So, question 3. A 38-year-old female with a nephrotic syndrome due to minimal change disease has responded to a course of prednisone with a complete remission, but she's relapsed 3 times whenever she discontinues prednisone. Which therapy will give her the highest remission rate at this time? She's had 3 relapses. Should she be put on cyclosporin, on cyclophosphamide, on tacrolimus, on mycophenolate, or all of the above equivalent? So it's not easy to find the data on this, but you can get it. So first of all, that this tells you here on this slide the definition of frequent relapsers and steroid dependent. Now, frequent relapsers are people who have had 2 or more relapses within 6 months of the initial response, or 4 or more relapses in any 12-month period. Steroid dependent, 2 relapses during or within 2 weeks of completing steroids. So those are the definitions that KDIGO guidelines give us. Here you can see the response if you take all the people who respond to steroids, which is the vast majority. This is taken from our paper with Merrill Waldman here, back on the 95 adults. You can see at the end of 6 months, 60% of them were relapse-free, 40% had already relapsed. And there'll be more relapses as you go out of time. So again, that relapses are very common. Frequent relapses, steroid-dependent, are a little less common. So what does KDIGO tell us about this? For frequent relapsing or steroid-dependent minimal change, if they've had no previous cyclophosphamide and the patient doesn't care if they're getting cyclophosphamide, give them cyclophosphamide. That if they had previous cyclophosphamide, or the patient wishes to avoid cyclophosphamide, which is 95% plus of my patients once I tell them the side effects, just mention alopecia, hair loss, or infertility with cyclophosphamide. Even if it's rare, you mention that, that's it. They're going to want one of these agents. We often use a calcineurin inhibitor, and then in some we add on rituximab. But nevertheless, these are the choices. And this just shows you from those 95 patients at Columbia, if you look at cyclophosphamide, this is for cytoxane, cyclophosphamide, cyclosporin, tacrolimus, or mycophenolate, add up the complete and partial remissions here. They're identical in all the groups. So again, if you're steroid dependent or frequent relapsing, you're going to respond to almost any of these over time. And again, it's best to say, well, what side effects has the patient had before? Do they not want to take any chances with cyclophosphamide? Do they are worried about hair growth with cyclosporin, etc.? You can pick the choice based on what their previous side effects are or what they're afraid of getting, rather than saying one drug is better than another. Okay, which clinical and laboratory features suggest an obese nephrotic patient is more likely to have secondary or hyperfiltration etiology than primary idiopathic focal sclerosis? So what tells you the patient is a secondary focal sclerosis here and not likely to benefit from immunosuppressive therapy? Is it a serum albumin of 2.4 and 9 grams of proteinuria? Is it a serum albumin of 3.8 grams per deciliter and 3.4 grams of proteinuria per day? Is it perihilar focal sclerosis in the absence of hematuria? Is it a BMI of over 40 and a plasma albumin of less than 2? So which of those is hyperfiltration secondary? The best scenario for that is an albumin that is really normal and moderate degrees of proteinuria. They may be up in the nephrotic range over 3 grams, but again, it's not 9 grams of proteinuria per day. Now, yes, a heavy BMI will go with this, but a plasma albumin of less than 2 is not typical. Yes, perihilar focal sclerosis goes with secondary, but the absence of hematuria doesn't help you at all. So again, it's less total proteinuria and a normal albumin. You have to think, is this a secondary form? So of course, in our secondary forms, we have our obese patient here, who has obese glomeruli. Here's a normal glomerulus. Look at the size of the tubules here. Here's the same size tubules, but look at that giant glomerulus, and here you can see they're getting a segmental scar right over here. This person should not be treated with immunosuppression. This person is over-filtering. They should be getting ACE inhibitors, ARBs, etc. Okay, question 5. Which genetic defect of focal sclerosis is not associated with an autosomal dominant inheritance? Straightforward factual question. Is it alpha-actinin 4, inverted formin 2, potocin, or TRPC6 channel defect, which is not autosomal dominant? And the answer is potocin. Potocin is an autosomal recessive form of steroid-resistant nephrotic syndrome that the others are all dominants. It's important to understand these because, again, you have to do family counseling. You have to see if the genetics fit in the family history when you're guessing which these are. But again, it is important to think about these in terms of the genetics of it, and you're expected to know this if you're taking boards these days. Question 6. Which disease, ultimately proven to be genetic by whole exome sequencing, is most commonly mistaken for focal sclerosis on light microscopy? You get back your biopsy report, it says focal sclerosis, that on light microscopy, you're missing either the IF or the EM, or even you may have it. That which one is most likely to be mistaken for focal sclerosis? Is it Nail-Patella syndrome? Is it collagen 4, alpha 3, 4, or 5 defects? Is it Fabry's disease? Is it tuberous sclerosis? So this is taken from a recent article in the New England Journal on a study we did at Columbia. Ali Gharabi was the senior author here, and Emily Glutman was the first author. They looked at over 3,000 patients, many of them from the Glomerular Center at Columbia. Almost 10% had a genetic defect, and in many it was not suspected. If you look at people with glomerular disease, here they are here in the orangish here, what were the most common defects here? Collagen 4, alpha 3, collagen 4, alpha 4, collagen 4, alpha 5. They were all basement membrane defects in the Alport thin basement syndrome group. So if you looked at them, a lot of Alport syndrome or thin basement membrane, and a lot that were thought to be focal sclerosis, but later on were later found out to actually be collagen 4 defects. So always think about this. You may be mistaken here. Doing the genetics makes sense in a lot of people, especially young people, people with a family history, that you can avoid immunosuppression in these patients. Okay, which statement is not true about focal sclerosis? The incidence of focal segmental sclerosis has increased in recent years in the U.S., and it is the most common pattern of idiopathic nephrotic syndrome in patients of African descent, African ancestry. The incidence of focal sclerosis has also increased in Caucasians in the U.S. The not otherwise specified, that is the classic pattern of focal sclerosis, actually has the worst prognosis. Focal sclerosis is the most frequent form of idiopathic nephrotic syndrome to lead to end-stage renal disease here. So which of these is not true? Okay, well, let's look at the data here. So this slide is taken from a study by Jeff Kopp from NIH. And in this study, they looked at a large number of patients here that following through in terms of the incidence of end-stage kidney disease due to focal sclerosis. Here you can see over time is the African American population, certainly in blacks, huge increases. Here is the total population, and there is an increase. And there is an increase in whites as well. So there is an increase in all groups here, but tremendously so in people of African American descent. This is taken from a study of biopsies that were done at University of North Carolina. over time. And you're looking at many, many thousands of biopsies over a period here of 20 years. Like that. You look at them, what's the number one disease back in 1986? What's the number one disease back in 2015? Focal segmental sclerosis. Now, some of these have gone down. Some of these have gone up because it's the percentage here. Here, if they're doing a study on diabetes, you'll get more diabetic patients in the study, but focal sclerosis has been there all along. This is taken from a study from Kaiser Permanente in California. They looked at all their patients with glomerular disease, biopsy proven. Here you're looking at focal sclerosis, membranous, minimal change, and IgA. The most common forms of disease that we see for glomerular disease, idiopathic quote. If you look over time, from 2000, over a decade, 2,500 patients, focal sclerosis rose up to be by far the most common pattern that was seen. So focal sclerosis is common. University of North Carolina, I can tell you it's always one of the top diagnoses we biopsy at Columbia, and it's common in California. The interesting thing about the Kaiser Permanente study was that they looked here at focal sclerosis here and other forms here in different groups. So if you take here white non-Hispanic, the number one disease was focal sclerosis. If you take African American descent, overwhelmingly focal sclerosis, Hispanic overwhelmingly, even in Asian, where you might think IgA would have been the most common, it was focal sclerosis. Whether it's the most common or one of the most common, focal segmental sclerosis has increased in blacks, it's increased in whites, it's the most common cause of end-stage renal disease due to glomerular disease here, that it's an important disease. Question 8. Glomerulosclerosis related to ApoL1 genes has been more prevalent in African American patients from backgrounds, sub-Saharan Africa, with idiopathic focal sclerosis. If you take people with idiopathic focal sclerosis, it's more common in blacks. Many of these people have inheritance from sub-Saharan Africa here, but it's not only idiopathic focal sclerosis. It's also been seen in 3 of these other diseases. There is an increase in abnormal ApoL1 genes. That is the G1, G2 genotypes, either G1, G2, G2, or G1, G2. So you get it in idiopathic focal sclerosis. You also get it in HIVAN. You also get it in COVID-associated nephropathy, COVAN. You get it in lupus. You get it in diabetes. So it turns out that this is common. These genes, ApoL1, G1, G1, G2, G2, or G1, G2, the abnormal variants here that lead to sclerosis, idiopathic focal sclerosis, HIVAN, COVAN, lupus, but not in diabetes. They just have not been able to prove this for diabetes. So we know there's a strong association of focal sclerosis with these ApoL1 genes. As I said, the G1 and the G2 alleles, as opposed to the G0, which most Caucasians and most people of Asian descent have, the G1, G2 alleles are associated with a multifold increased risk of focal sclerosis. In some, it's an 80-fold increased risk. It is not a dominant or recessive matter of inheritance. It's just a predisposition. Why is this? If you look at where this is in sub-Saharan Africa here in terms of this, you're looking at the wild type, and here you're looking at the G1 and G2s. That ApoL1, G1, G2 genes select for a prevention of trypanosomiasis brucei, sleeping sickness. If you have one copy of this gene, G1, G2, the sleeping sickness parasites have trouble getting into your red cells. If you have 2 copies, they can't get in at all. So again, it prevents sleeping sickness, which is a huge genetic benefit in sub-Saharan Africa. Fortunately or unfortunately, we have no sleeping sickness in New York City. So when people have 2 of these G1 or G2 alleles, they have more sclerosing lesions in kidneys in the glomeruli here, but they won't get sleeping sickness in New York City. So what has this been associated with? Focal global sclerosis, again, in people of African American descent. Focal segmental sclerosis, FSGS. HIVAN, HIV-associated nephropathy. COVAN, COVID virus-associated nephropathy. And also in lupus and in sickle cell nephropathy. As I said, it has not been shown to be significantly increased in blacks with diabetic nephropathy. So still, sclerosing lesions, very important to know about. It's also very important in terms of transplant, because again, if you have a donor that has two of these genes, that donor kidney is more likely to develop sclerotic lesions over time. It's not the recipient, it's the donor kidney that is important in this with the ApoL1. And we do test for this now pretty commonly. Okay, this just shows you COVAN-associated nephropathy. Again, that who knows, where we are in this pandemic, if it's going to spring up again. But the typical lesion is a collapsing focal segmental sclerosis lesion. You have segmental sclerosis in some, you have total collapse in other glomeruli here. This is taken from a series of 23 patients with COVAN-associated nephropathy, nephrotic syndrome, collapsing glomerulonephritis here from Colombia. This is all from Colombia. 91% of them were African American. 94% with these collapsing COVAN lesions had the ApoL1 genotypes, G1, G2. The other thing it's important to remember is that if you're looking at bad types, that the phenotypes that you can find on a kidney biopsy, that here is remissions, here is end-stage kidney disease, and all focal sclerosis in a series from Colombia. Here you see the tip lesion. Almost everybody remits. Very few go on to renal failure. Here's collapsing. Few remissions. Most go on to end-stage kidney disease. So collapsing has a bad prognosis. The classic, not otherwise specified, is just like all the others. Again, it's really tip lesion is better. Collapsing is worse. Okay, let's move ahead now to a 64-year-old male with 12 grams of proteinuria per day, a serum albumin of 3.2, his estimated GFR is 28 cc's a minute, and he has a biopsy which shows membranous nephropathy. He has positivity for the phospholipase A2 receptor staining on the biopsy, which is true about thrombotic tendencies in membranous nephropathy. In membranous nephropathy, remember, there's an increased risk of renal vein thrombosis, of clotting, of DVT and everything, more so than most other forms of nephrotic syndrome. So what's true about it? Anticoagulation will not be beneficial unless the serum albumin is below 2. Data support prophylactic use of oral NOACs, the oral agents, over warfarin to prevent thrombosis. Here we're talking about apixaban, rivaroxaban, etc. Anticoagulation has not proven beneficial in membranous nephropathy patients who are PLA2R antibody positive. Anticoagulation should be based on an individual risk-benefit strategy. So which of these is true? So this is what you get from KDIGO. They say if the serum albumin is below either 2.5 or 2, that somewhere the cutoff is someplace in that, depending on how you do that here, that those are the high risk. If it's above that, you're low risk, that you can estimate the thrombotic risk here in terms of this and decide if you want to use aspirin or no aspirin, but you certainly wouldn't anticoagulate anybody at this point here, especially if their albumin is above 3. That if they're high risk, you can access the bleeding risk tool that's given for you right down here. You can go to online and get the bleeding risk tool and see how high a risk they are. That if they're high risk for bleeding and for clotting, use aspirin. If they're high risk for clotting but low risk for bleeding, use warfarin or low molecular weight heparin. Now this is taken from Up to Date. We do not routinely prescribe direct oral anticoagulants, the DOACs or NOACs, new oral anticoagulants, whichever you want to call them, as prophylactic anticoagulation in membranous, given limited data. You may consider DOACs in patients with side effects or inadequate therapeutic effects from warfarin, and if the patient is unwilling to take low molecular weight heparin. So NOACs, DOACs are not here yet for anticoagulation. You have to consider the risk and the benefit. It's really assessing each individual patient, what their albumin is, how high their risk is, and how high their risk for bleeding is. That's your clinical judgment. Now, this just shows you membranous nephropathy. Here's a case of renal vein thrombosis. Here you can see the outline of the kidney would be like this. These are venous radicals. Here's clot in the renal vein, going into the radical into the renal vein, going into the vena cava. That's a vena cavogram. We don't do those anymore, but we do, CT venography. Here's a normal kidney. Here is a swollen kidney. Here's the renal vein, and you can see clot right here going into the renal vein here. And here's a patient who had membranous nephropathy, got admitted to 2 New York City hospitals in a 1-month period for, quote, pneumonia, cough, low-grade temperature, shortness of breath. When she came to see us in clinic, she had dilated veins all the way from the hypogastric up to the axillary here. She had total right renal vein occlusion, partial inferior vena cava occlusion associated with her membranous nephropathy. Okay, which autoantigens on a biopsy of a patient with membranous nephropathy have been associated with tumor? You're all familiar in terms of checking now for PLA2R antibody in the serum, looking for it on staining here, but they can test for SEMA-A3B. They can look at exostocin 1 and 2. They can look at NEL1. They can look at the PLA2R. They can look at thrombo7A. So which one are associated with tumors? So SEMA-3B is associated in kids with membranous, again, and it's rare. Exostocin 1 and 2 are associated with membranous lupus. And actually, I'll be talking about that when I talk about membranous lupus. PLA2R, is present in about 70 to 75% of, quote, idiopathic primary membranous. NEL1 and thrombospondin 7A are 2 common antigens found in membranous nephropathy, and they are associated with tumors. So here you're looking at a manuscript that looks at the malignancy-associated membranous here. That if you look at PLA2R positive patients here on the biopsy, 35 of 829 had a tumor of some sort, 4.2%. If you look at thrombospondin 7A, which we've known about for over a decade now, it was 4 of 37. It was 11%. If you look at NEL1, it was 30 of 91, 33%. Now, when we have a membranous at Columbia, they not only stain for PLA2R, but they also can stain for NEL1. And if you see a right positive NEL1, we look harder again, looking for tumors. So thrombospondin 7A, NEL1, if you get a positive antibody or you get a positive staining on the biopsy, think, could this be tumor related? And there'll be more of this later on. I'm sure someday we'll have a panel that we'll put out looking for, what antigens are in the biopsy and what antigens do we have antibodies circulating against. Okay, so now we're up to a patient here who has the following biopsy. So we're looking at this biopsy here and looking at this pattern. What could this be associated with? Is it hepatitis C and hepatitis B positive serology? Is it SPEP, UPEP, and free light? Is ANA complement level here, or is it anti-GBM? Which one would not be searched for? Which of these tests would you not do in somebody with this biopsy? So you could do every one, of course, but it turns out that this is a classic membranoproliferative. You can see the lobular nature here of the glomerulus. You can see tram tracking, double contour of the basement membrane here in many places here. This is typical of hepatitis C. It's often can be found. Most hepatitis B is membranous, but it can be found, so you certainly would do the serology there. It can be seen in dysproteinemias, so you do an SPEP and a UPEP, especially in an older patient. ANA and complement levels, yeah, to be seen in lupus. An MPGN pattern is typical of lupus. It is not typical of anti-GBM disease. Anti-GBM disease is a crescenteric glomerulonephritis. You almost always have crescents. Here you can see a big crescenteric lesion here, breaks in the basement membrane here. Here's another one with gap in the basement membrane and a crescent forming. And here you're cutting it through sort of like over here. You're making like a cut like this. So you only see a little bit of the glomerulus. You just see a big crescent here. So think anti-GBM when you see a crescent lesion. Okay, question 12. For which glomerular disease has rituximab been approved for use by the FDA? You use it all the time for many diseases, but which one is FDA approved? Is it diffuse proliferative lupus nephritis? Is it ANCA-positive vasculitis? Is it IgA nephropathy? Is it membranous nephropathy? So which one of these? So, of course, there is data on membranous nephropathy. This is taken from the Mentor trial from the New England Journal, showing that whether you used rituximab or cyclosporin, at 1 year you were at the same place, but the rituximab-treated group had less relapses over time. Now, some people have said the recent Starman trial didn't confirm that. The Starman trial looked at what it was we call a Ponticelli regimen of alternating steroids and cyclophosphamide here. It looked at a calcineurin inhibitor followed after 6 months by rituximab, not given together. It was sequential therapy. A more recent trial looked at the Ricyclo trial, looked at rituximab versus the cyclic Ponticelli regimen here. And you can see proteinuria fell equally, albumin came up equally in both of them. The cumulative freedom here, remission was exactly the same. So again, there is a usage for rituximab in this. But it turns out, if you take membranous right now, KDIGO says, look at the risk evaluation. If they're low risk for progression, little proteinuria, good GFR, wait and see. Moderate, you can use rituximab or a calcineurin inhibitor plus steroids. Higher risk, use rituximab or cyclophosphamide plus steroids, or a calcineurin inhibitor with rituximab. That's what I'd use at Columbia. Very high risk, use cyclophosphamide and steroids. Again, that's KDIGO. Some people would do differently. Other people would say, look, this is my first choice again. But most people are in this category if it's a high-risk patient. And of course, the disease which is FDA approved is ANCA vasculitis. This is the RAVE trial, which was published at the 6-month and the 18-month data here. If you looked at patients here who got rituximab versus cyclophosphamide for ANCA-positive vasculitis, the newly diagnosed patients, the 100 of them came out exactly the same in terms of complete remission by 6 months. Relapsing disease actually did better with rituximab than did with the cyclophosphamide. Okay. Question 13. SGLT2 inhibitors have been shown to significantly slow the progression of which glomerular disease? You see them advertised for CKD on TV all the time now. And, that's dapagliflozin, but of course the data on EMPA is going to come out soon. So where has it been shown to be effective? Alports, focal sclerosis, membranous, or IgA nephropathy? So this is taken from the subset of those thousands of patients in the original CKD study. 270 patients had IgA nephropathy. And 94% of them were biopsy proven at the time here, etc. They either got 10 milligrams of dapagliflozin or placebo. Almost all were getting an ACE or an ARB as well. At 2.5 years, the primary endpoint was reached. A bad endpoint was reached in 4% of the DAPA. 15% of the placebo reached that endpoint, doubling the creatinine, etc. GFR decline was less with DAPA than it was with placebo, and the proteinuria decreased more with DAPA. So here you can see again the primary endpoint, no matter which one you look at here, biopsy, unbiopsied, etc. Placebo reached that progression to renal failure or progressive decline in GFR more than the DAPA did. It's only for IgA. We don't have the data yet for focal sclerosis, for membranous. They just weren't enough in that original study. We'll get more data as it comes along. You still could consider using it in some of these patients, but again, it wasn't statistically significant enough. Okay, a 22-year-old has a creatinine of 1.8 and 2.4 grams of proteinuria per day. On physical examination, the following skin changes are found. You examine him and you say, here's his umbilicus here. Look at these lesions around it. Here, again, skin lesions. Which one of these would not be found in this patient? Here's an eyeball. Here's two pair of hands. Here is basement membrane here. Here's podocyte. Here's glomerular basement membrane here. So it turns out that person has angiokeratomas corpus diffusum. That is Fabry's disease. And of course, it's the bathing suit area that the males get these findings. They do get eye ground changes and lens changes that you can see with a slit lamp. They get acroparesthesias in their fingers and hands. On biopsy, the EM, zebra bodies in the podocytes and the epithelial cells, but especially here, the visceral epithelial cells are loaded with these zebra bodies. What they don't get is laminations here of the basement membrane that are typical of Alport syndrome here, these lamination basket weaving, so-called, of the basement membrane. So 4 would not be found in that patient. A 28-year-old that has a 2-year history of proteinuria and has this biopsy here, which is not likely to be found with this lesion. A positive ANA, C3 nephritic factor, low factor H level, low C3 level. So the answer is a positive ANA. This person has a membranous proliferative picture here. Again, you can see the lobulation of the glomerular. The old name was lobular glomerulonephritis. But they have dense deposits all along every bit of the basement membrane. This is dense deposit disease. You get the picture like this by light. You get C3 deposition along the basement membranes and Bowman space here, and you get the EM, electron dense deposit. That's dense deposit disease. But the sister disease, which may have a totally different light microscopic pattern, still has C3 and gets small amounts of deposits, again, along the basement membrane, but you don't get the dense deposit. But they're both caused by the same thing, the alternate pathway of complement being activated. It's important to remember these diseases because we already have at least 3 anti-complement diseases. We have eculizumab, we have ravulizumab, we have avacopan. Again, for different diseases, we have a number of treatments for complement-mediated disease. And the last question. A 62-year-old is evaluated for proteinuria and edema. Blood pressure is pretty good, has an S4 gallop, no liver, kidney, spleen, with 2 to 3 plus edema. Creatinine is good at 0.7. His urinalysis has 4 plus protein. The 24-hour protein has 4.2 grams a day. ANA complement, hepatitis B, C, HIV, all negative. He has 1.8 grams of IgG kappa spike in his serum, and his albumin as well. And again, he has edema, he has proteinuria, normal GFR. Which is least likely to be found? Number 1, here's a glomerulus. Here's the afferent arteriole. Number 2, here's IF staining for kappa. Here's number 3, basement membrane here, electron dense deposits, subendothelial, epithelial as well. Here's a tubule. So this is amyloid. This guy has albuminuria. He has proteinuria, that he has significant proteinuria with it. He could easily, with his IgG kappa spike, have amyloid. He could have light chain deposition disease with outlining of all the glomerular capillary loops and Bowman's capsule and all the tubules as well. He could have proliferative GN with immune complex deposits. This is becoming more and more common. What he would not have is myeloma cast nephropathy, because here you can see typical fractured casts here, multinucleated giant cells. That would give you tubular dysfunction and an elevated creatinine. His creatinine is normal. He has a glomerular disease with proteinuria, but no major renal dysfunction at this time. So I hope you got all of these correct. If you did, you're in the standing for getting a new Mercedes-Benz. No, that's not really true. But if you did get them all correct, you're a smart guy. And if you didn't, just means you have to look at more biopsies and think more about glomerular disease. Thank you very much.